بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيدنا محمد أشرف خلق الله أجمعين. It is my great honor and pleasure today to introduce the great summit between Arab world and Pakistan. In the same time, we have in Cairo the Pakistan African Summit, Trade Summit, but we are here to have a very elegant scientific summit. All my appreciation and greeting for all my dearest colleague in January 6 and January 13 summit. Thank you for your time and effort. Welcome to the highest point of the sky for all my dearest colleague. Welcome in Isaac online program and all appreciation and greeting for your effort and time. Thank you. I will let my colleague Yasser Rida to introduce you. Thank you all. Dr. Yasser. Dr. Yasser.
Okay. It's okay.
Dr. Yasser.
You hear me now?
Yes.
Yeah.
Yes, it's okay. Thank you very much, Dr. Safa, for the collecting this group, fantastic group from all over the world. I was proud to present my colleague Shahzad Anwar a couple of days ago as a pioneer and first one just certified from Pakistan in regenerative medicine. And today I'm also proud to present this time my colleague and my faculty in Gulf Business School, also my teacher, because I just get a very first step in regenerative medicine. And today we have two stars from Iraq, and this two stars, the first also to be certified from American Board of Regenerative Medicine in Iraq. We have one belong to anesthesia, and this is, as most of people attended. But the great thing about that, Dr. Abdul Majid is the clinical hematologist, and I think he's nearer to understand what's going in the body more than us. But also Dr. Khalil, one of the pioneers in this branch, he understand what's going on, and also he tried to be in the way to use an ultrasound and image to put the medication in the perfect areas. Doctor, as I said, the first to be certified in Iraq. Um, I return back to Dr. Abdul Majid. He's the head of regenerative medicine section in Zaytun Hospital. He's a pioneer in cellular therapy in Iraq. Have many research in the field of regenerative medicine and also innovation with Dr. Khalil. They make as a group and innovation and research in this area. And also the second member in the group or second star for today, Dr. Khalil also is my colleague and I attend with him Gulf Business School as a faculty. And I learned from Dr. Abdul Majid the last time I meet him and Dr. Khalil a lot about regenerative medicine. This is what's called the hole in pain medicine need to be sealed. Most of the time we have patient, whatever you do for him, at the end he don't get any resolve it from the pain. And I think not just pain, because Dr. Abdul Majid working in other type of specialty away from pain, but I think this part of regenerative medicine can just cover a big area in pain medicine, which sometimes we can't do anything for the patient. Dr. Khalil is certified as international procedure in regenerative medicine and the American Board of Regenerative Medicine also. And he has this intervention integrated pain management in 2021. This is accredited by Gulf Business School and International Association of Study of Pain. Also, Dr. Khalil interesting in ultrasound guided procedure and have a diploma in ultrasound guided, have a fellowship of Iraq Board of Medical Specialists in Anesthesia and Intensive Care. He has also a strong credential and experience in the field of regenerative medicine and pain intervention, regional anesthesia. And I think he make a very great team with Dr. Abdul Majid. Now the plane just start to fly it in the sky of regenerative medicine, and the stage for you, Dr. Khalil and Dr. Abdul Majid. You can start, Dr. Khalil. You start first, inshallah.
يا دكتور خليل.
Yeah, شكرا دكتور خالد تفضل.
Regenerative medicine application, musculoskeletal and other field. We have regenerative medicine. We start as a basic, an introduction, and but very short because it's a big field. Regenerative medicine process of creating living functional tissue to repair or replace tissue organ function lost due to age, disease, damage, congenital defect. It's helped to produce extended healthy longevity. Here, the future of the medicine in order to solve the clinical challenges related to untreatable condition affecting cells and tissue and organ function. This field of medicine using basic research to relieving suffering of million people complaining from end organ damage resulting from chronic illnesses. Stem cell foundation, every organ tissue in a human body are there for many different types of stem cells. Here the types of stem cell, we have embryonic stem cells, adult stem cell, and induced pluripotent stem cell, Okay, here embryonic stem cell that exists only in the earlier stage of development and various type of tissue specific or adult stem cell that appear during fetal development and remain in our bodies throughout life. Adult stem cell, here we can use bone marrow and
peripheral blood stem cell.
Yes, stem cell, adipose, dental pulp, endometrial cord blood, and induced pluripotent stem cell. Cellular product, here we are talking about cellular product. Mononuclear stem cell can be harvested from three sources. This is from bone marrow, peripheral blood, and cord blood cell. Our manipulation, me and Dr. Abdul Majid, in minimal manipulation, this iceberg, minimal manipulation, but the depth of the job is nanotechnology, immunotherapy, tissue engineer, and gene therapy. Dr. Abdul Majid, he will talk a lot of this. There are three primary sources of hematopoietic stem cells for patients needing transplant. We have bone marrow historic source in 1956, 1 to 4% of bone marrow nucleated cell. Second, mobilized peripheral blood in 1986, 0.5 to 10% of peripheral blood nucleated cells. Three, we have umbilical cord, 1988, 0.2 to 2% of cord blood. I will talk brief about platelet-rich plasma. PRB definition is a portion of blood fraction, autologous blood having platelet concentration above the baseline in clinical use since 1987. PRB properties has a growth factor agonist, mitogenic, chemotaxis, promote a new capillary growth, suppression of cytokine release, tissue senescence, and antimicrobial activity limit. We will talk about later. Platelet PRP growth factors, we have the platelet granules, we have lysosome, desigranules, alpha granules. Platelet alpha granules comprise about 10% of platelet volume, 50 to 80 alpha granules per platelet, 200, 500 nanometer in size, developed in megakaryocyte vesicles budding from Golgi apparatus, continued development in mature platelet endocytosis, becoming exosome upon platelet activation. This is other subject about exosome. We have a big issue about this exosome and how to get this exosome. Platelet activation mechanism. Activation mechanism collagen, thrombin, calcium chloride, calcium gluconate, cold temperature, mechanical manipulation. Platelet activation, tissue collagen is regarded the most potent activator for platelet. PRP activated exogenously by thrombin, calcium chloride, or mechanical trauma. On a workshop, we will show you how we can activate platelet. Employing non-activated platelet may result in more physiologic activation by tissue into which it is injected or applied. Platelet activated in a more physiologic manner may form more stable tetramolecular network, which enhancement of the cell and growth factor. Sorry, as I am rapid talk or hello?
Dr. Khalil, try to be rapid in these basics. Yeah?
Okay. Platelet activation. Optimize option dilution, saline dilute to 25%. Lower anti-angiogenic potential. Temperature preconditioning. Here, temperature preconditioning for activation and for platelet lysis 4 degrees centigrade, incubated for 30 minutes, increase alpha granular release. This is the future of regenerative. Stem cell interaction, maintenance of stimulants, stem cell proliferation, migration, homing, and differentiation and stem cell adhesion. The secretory protein of the PRP growth factor, stromal cell-derived factor 1, vascular endothelial growth factor, platelet-derived growth factor, transforming growth factor, platelet growth factor 4, platelet-derived angiogenesis factor, epidermal growth factor, platelet-derived endothelial growth factor, epithelial cell growth factor, insulin-like growth factor. Cytokine, this is a family of 11 cytokine discovered in studies of pathogenesis of the fever. The first synthesized precursor protein, then cleaved. Pro-inflammatory cytokine act by integrin expression, leukocyte, and endothelial cell, based on interleukin 1 alpha and beta, natural antigen antagonist, interleukin 1 RA, interleukin L1 receptor antagonist. Here, healing cascade, all over, you know, this the healing cascade starting since the injury, the inflammation, then from 0.1 to 10 days, then proliferative start from day 1 to 13 days, then remodeling cascade formation. Platelet angiogenesis study. Platelet gel prepared from platelet concentration 0 to 7.5 million per microliter. Study were performed at 24, 48, and 72 hours. Optimal concentration for platelet stimulation for angiogenesis was 1.5 million per microliter up to 3 million. Because lower than that level, it has less angiogenic. More than more than 3 million, it will be suggest inhibition. We have leukocyte-rich, leukocyte-poor PRP. Here, also randomized control study. We have evidence 1 level and 3 prospective comparative study with total 1,055 patient injection of leukocyte-poor PRP. Here, the results significantly better WOMAC score than did injection of hyaluronic acid. The mean difference minus 21.14, 95% CL, and minus 39.36 to 2.65, or placebo. Placebo, the mean difference, minus 70.84, 95% CL, and minus 34.95 up to minus 0.73. The soccer analysis showed that the low leukocyte pool was the highest ranked treatment for both measurement of a clinical efficacy, which is WOMAC and IKDC. PRP injection result in higher incidence of adverse reaction than hyaluronic acid food ratio. This is the ratio. Conclusion. Leukocyte pool PRP result improvement functional outcome, and we have more study, me and Dr. Abdel Majid, and in advanced osteoarthritis. Leukocyte pool PRP result improved functional outcome score compared with hyaluronic acid and placebo when used for treatment of knee OA. Leukocyte pool PRP and leukocyte rich value similar safety profile, although induce more transient reaction than does hyaluronic acid. Adverse reaction to PRP may not be directly related to leukocyte concentration. Here, a platelet p-selectin test. P-selectin who brought it's a protein cell adhesion molecule, and it's found in alpha granules of a platelet. This p-selectin. P-selectin cytometric analysis, flow cytometry guided on pan platelet positive events, p-selectin negative events, and positive events. I don't know, you maybe you see clear this CD41.
You can run it quick so that you can
run
it.
Yeah. PRP, worldwide standard method preparation of platelet transfuse is Puffy-Cut method. Platelet concentration containing 5% of baseline red cell mass. Platelet maintain their function and viability, radioactive survival throughout 5 days of storage at 22 centigrade. Typical PRP treatment released alpha granules content for about 5 to 7 days. This is this time 5 to 7 without activation for release of alpha granules. Platelet-rich fibrin. Fibrin clot, here leukocyte, platelet, and fibrin. In here, we don't use anticoagulant. Typical for wound care and dental regeneration. Platelet lysate vice PRP. Definition: lysis of a platelet cell wall followed by removal of cell fragment. Here, expose the PRP to freeze thaw cycle. Expose PRP to ultrasonic cavitation. This is our method, me and Dr. Abdel Majid, and high-speed centrifugation for removal of cell debris. Compared to PRP, platelet-rich lysate, platelet lysate, yes, release alpha granules, growth factor cytokine immediately vice over the 5 to 7 days with PRP. More complete release of alpha granules. Platelet poor plasma. Here, platelet content less than 10, yes, per macroliter, elevated fibrinogen, fibrin scaffold potential, angiogenic properties, VGF factor, R2 CD marker 34. Manual versus automated PRP comparison.
Go to conclusion. Yeah.
So yes, the conclusion for this
Yeah.
double spin method has a higher platelet capture efficacy, resulting in higher platelet concentration as compared to automated device. There was significant individual variation in platelet yield and PRP proceed both methods result more consistent with a manual method. Okay. PRP storage. Yes. The novel method for preparation of freezing storage of a growth factor and cytokine obtained from platelet-rich plasma. Here, the optimal protein concentration analysis showed that no satisfactory significant difference in composition of PRP when platelets were activated by thrombin or mechanical activation. There was also no statistically significant difference in concentration of cytokine and growth factor. In PRP autologous composition, after storage of 9 months at minus 18 centigrade, mechanical activation is an efficient method to activate PRP. Conclusion. PRP-derived autologous composition is capable of being stored for up to 9 months without affecting concentration of analyzed protein. Clinical evidence summary. Here, the clinical recommendation for the use of PRP. Here, lower leukocyte-rich PRP injection for lateral epicondyle. Leukocyte-poor PRP for osteoarthritis of the knee. This is the evidence summary. Moderate high quality evidence support the use of leukocyte-rich injection for patellar tendinopathy, plantar fasciitis, and the donor site for pain, patellar tendon graft, anterior cruciate ligament reconstruction. PRP clinical evidence summary. Insufficient evidence for routinely recommended PRP for rotator cuff osteoarthritis, high ankle sprain. Lack of efficacy PRP for Achilles tendinopathy, muscle injury, acute fracture or non-union, surgical augmentation or rotator cuff repair, Achilles tendon repair, and anterior cruciate ligament reconstruction. PRP summary. Worldwide standard method for preparation platelet for transfusion is the Puffy-Cott method. The ideal PRP concentration 3 to 5 the host platelet count. Typical PRP treatment is the release alpha granules content for about 5 to 7 days. Platelet lysate may have more immediate and profound release of growth factor than PRP. Platelet concentration require increased angiogenesis. 1.5 million platelet per microliter. Tissue healing appear to be ideal at the platelet concentration of 1 million platelet per microliter. Okay, bone marrow aspirate concentrate. Bone marrow mesenchymal cells significantly decline with age. Quantitative and qualitative decline. Bone marrow aspirate concentrate primarily concentrate mononuclear cell, lymphocyte, monocyte, and hematopoietic stem cell and mesenchymal stem cell. Bone marrow BMAC contains similar concentration of trophic factor compared to PRP. Multi-site bone marrow aspiration do not appear to be superior over one single site. Small volume syringe appear to be to offer an improved bone marrow aspirate over large volume syringe. Rapid draw speed during bone marrow aspirate appeared to prove improved production over slow aspiration. So we have rapid is better, single site is better, small syringe. Bone marrow mesenchymal cell versus adipose. Comparative analysis of a human mesenchymal cell from bone marrow and adipose under xeno-free condition for cell therapy. The result condition, adipose tissue-derived mesenchymal cell have biological advantage in proliferative capacity, secreted protein, basic fibroblast growth factor, interferon Y, and insulin-like growth factor, immunomodulatory effect. Bone marrow-derived mesenchymal cell advantage in osteogenic and chondrogenic differentiation potential, secreted protein, stem cell derived factor 1, and hepatocyte growth factor. Adipose stem cell summary meet the majority of criteria, international criteria for MSC. Majority of adipose are adipocyte precursor cell. Proliferation potential of ADSCS higher than bone marrow MSCS. Adipose stem cell may have a higher immunomodulatory potential over bone marrow mesenchymal cell. Adipose and bone marrow mesenchymal cell similar differentiation potential. Meniscal injury. Here we have a lot of cases of meniscal injury. Level 1 evidence PRP augmentation in meniscus surgery appear to be beneficial post-operative pain and functional gain meta-analysis. Here I use it even without operation, direct better improvement. Precaution mesenchymal definition augmentation with PRP result in significant improvement in the rate of chronic mesenchymal tear healing. Rotator cuff tear. PRP injection follow partial medial meniscectomy appear to be reduced postoperative pain and lead to improved meniscal tissue regeneration. Anterior cruciate tear. Here, anterior cruciate tear, level 1 evidence, reduction in swelling and CRP level suggesting PRP could be benefit in acute stage of recovery system. Here, level 1 injury, this first before 2 years, anterior cruciate. I tried to how to train to find anterior cruciate under ultrasound guide. Then I start to inject an anterior cruciate. Single allogenic MPC injection following ACL reconstruction was safe, well tolerated, and may improve symptoms and structural outcome. Rotator cuff tear. ACL tear summary, level 1 evidence, reduction swelling and CRP. Level suggested PRP could be a benefit in acute stages of recovery. Systemic review. Single allogenic MPC injection follow ACL reconstruction was safe, well tolerated, and may improve systemic and structural outcome. Here, stem cell and knee joint osteoarthritis summary. Level 1 evidence, treatment with mesenchymal cell and PRP show good clinical efficacy in improving pain and joint function. Patient with knee OI meta-analysis. I work about more than 1,000 cases in OI with mesenchymal and PRP. For patient with OI, intra-articular injection autologous ASCS or ASADS SVF without adjuvant treatment showing remarkable clinical efficacy and safety at short term. Follow-up meta-analysis. The source of mesenchymal cell and superior to allogenic source of mesenchymal with regard their consistent efficacy for pain, functional outcome, and safety. Culture expansion of autologous mesenchymal cell is not necessary factor. Obtain superior result in management of neosteoarthritis meta-analysis. Stem cell NEOA summary level 2 evidence. Intra-articular injection mesenchymal cell without any adjuvant therapy improve pain and function for OI. Significant better outcome were obtained with the use of bone marrow compared with adipose mesenchymal with the use of cultured mesenchymal as opposed to uncultured mesenchymal. PRP and hip osteoarthritis. Patient with level 1 evidence, patient with early OI, KL grade 1, 2, or Tony's grade 2, had greater benefit effect on outcome was maintained long-term at the 12-month follow-up meta-analysis. Intra-articular injection of PRP was associated with significant reduction of VAS visual analog score at 2 months compared with hyaluronic acid meta-analysis. PRP injection offers significant and stable clinical improvement in patients with OI at 12 months without relevant side effect. The condition of PRP and hyaluronic acid did not lead to significant improvement in pain symptoms, rotator cuff tear. Stem cell and osteonecrosis femoral head. This take from me and Dr. Abdel Majid, very, very big time. We work on osteonecrosis femoral head, level 1 evidence compared with CD treated alone in the treatment of ONFA-H combined utilized of CD and autologous BMC SCS implantation has better than relief and clinical outcome and can delay the collapse of the femoral head more effectively. Here, I have comment about level 1. They say they have better and delay the collapse. For me and Dr. Abdel Majid, we try to delete this statement about the delay of collapse. Maybe I send you about femoral head necrosis and our job. Level 2 evidence, stem cell therapy combined with core decompression is more effective at preventing collapse, radiographic progression, and conversion to total hip arthroplasty. PRP and rotator cuff evidence meta-analysis, leukocyte-poor PRP. Leukocyte-poor PRP can improve the clinical function and reduce re-tear in arthroscopic rotator cuff repair. In contrast, efficacy of leukocyte-rich platelet plasma was not significant improved with the exception of the VAS score, visual analog score. Meta-analysis of selected study showed that PRP injection was safe and effective intervention for long long-term pain control and shoulder function in patients with rotator cuff disorder. Significant reduction in retear rate where rotator cuff repair augmented with PRP. Platelet PRP appear to be the most effective formulation, resulting significant improvement rotator cuff clinical outcome score has been compared to the control. PRP treated with arthroscopic repair for rotator cuff tear decrease the retear and the rate of improvement in the clinical outcome. Stem cell and rotator cuff summary. Level 1 application bone marrow aspirate constraint at the time of RCR was associated with significant decrease in incidence of revision surgery. Level 2 bone marrow aspirate constraint with PRP improve pain and shoulder function in patients with partial tear of rotator cuff tendon. No clinical outcome change in treatment of group, but statistically significant anti-structural changes with adipose mesenchymal stem cell and fibrin glue. PRP and spinal disc. Level 1 evidence, intradiscal PRP resulting in significant functional improvement at 1 year. Mark intradiscal PRP lumbar degenerative disc disease showed significant benefit for pain and function at the 5 to 9 year follow-up as a subset patient. Here, I think the other part of this PowerPoint, we have a picture, radiological picture for patient. We are using intradiscal biomaterial, and we have good, very, very good result. But I think there's a problem in laptop of Dr. Abdelmajid. Stem cell and lumbar degenerative disc disease, evidence 1, mesenchymal therapy could significant adverse VAS, visual analog score, and ODE score in patients with DD meta-analysis. Intradiscal injection could be safe, effective, and durable, minimal invasive therapy. For the subject, we have chronic lower back pain associated with moderate degenerative disc disease. Mesenchymal stem cell appear to be a valid alternative treatment of regenerative disc disease because they can provide effective and durable pain relief together with the objective improvement of disc degeneration. Subset of allogenic mesenchymal cell treatment lumbar degenerative disc disease patients show significant improvement at 12 months. This is me and Dr. Abdelmajid for knee degenerative osteoarthritis of the knee joint. And this is Dr. Abdelmajid for hip and Ibn Sina training hospital in Baghdad. This is a presidential hospital. Patient with osteonecrosis femoral head. And this under ultrasound, I use ultrasound and fluoroscope combined technique. This is in Al Zaytun private hospital. This is our place with the agreement from Ministry of Health for using of stem cell. Okay, here hematopoietic blood stem cell. Dr. Abdelmajid, this is your part or my?
Yes, I will start here.
Okay.
But try, Dr. Khalid, try to be with me and try.
Yes.
Some slides have video, so we should run the video. So I will start. with
Yes.
hematopoietic stem. I'm really glad to be with such amazing group, Dr. Safa, Dr. Yasser, Dr. Shahzad, and Dr. Khalil, and all other people, Dr. Abir. We are talking about my experience, which started with hematopoietic stem cells 20 years ago, more than 20 years ago, really. And we started with hematopoietic stem cells. You can run to the other slide. The bone marrow, the stem cells can be collected. The other slide, please. Dr. Khalil.
Yes.
The other, yes. You can, with my talk, you can go on. So we can collect stem cells either from the bone marrow, the first picture. No, the above, still we need the other. No, previous slide, previous.
Yes.
The other previous one. The first one.
This
Yeah,
is the
this
first.
one.
This is the first.
The second.
Yes.
Second one. Yeah. The other one. Other one. Next. So it seems we jump to this. We have two types of machines. We have the intermittent centrifugation. No, just go back, please, Dr. Khalil. No,
Yes.
no, just go. No, go back.
That, okay.
Still. Another one. Yeah, just stop here.
Yes.
This
Okay.
is no, just stop with
Yes.
the hemolytic.
Okay.
The other slide.
Next.
Yeah, next.
This
Next.
is next.
Yeah, just stop here. No,
Okay.
just wait.
Okay.
So we have the hemonetics, the MSC plus instrument, which is using intermittent centrifugation. You take the blood from the patient and you return it back. And this is the first slide. The second one, which is Fresenius instrument, which uses double veins. You take from the vein and you return it at the same time. So it is continuous centrifugation. Next slide.
Next.
Yeah, stop here. This is called Spectra, the old version of cell separator. Next slide. Next slide, please. Stop here just. This is Opti, the new version. This workshop was done in Egypt last year in August, talking about cell separators. Next. It's being late. دكتور خليل ليش يتأخر هذا؟
هو delay.
بس هذا فيديو، هذا ماشي فيديو. This is video. This was video. بس دوس عليه بالكيرسر.
Not working. This video not working because yes, my window 11.
Okay,
11 not
stop.
working.
Okay, stop here. This is a dentist, a patient. We run this experience was in 2010. So it's a long period of time. We started patients with multiple sclerosis. We treated them with intrathecal injection of peripherally mobilized stem cells. I use these cells separated from the MCS plus, and we give it some of them intrathecal injection, and we got very good improvement. Next slide. So we have
not work as a video.
Just here you cannot run the video. This one of the first patient that we did, he is from UK. He was the first patient with multiple sclerosis. He was secondary progressive. You know, in multiple sclerosis, we have relapsing remitting, we have primary progressive, and we have secondary progressive. So this patient was primary progressive disease and was in a bad status. He is from Britain, he is from UK, and I did an experiment with using also peripheral mobilized stem cells, and I injected intrathecal, and he got a very good improvement in the EDSS score of multiple sclerosis. So his wife, his doctor, was amazed with the results. Next. Next slide. So this was my picture with this patient who was in Dubai. This patient has undergone a cord blood transplant in the 80s, and he is now 30 years of age. Next. So it's slow.
Yes,
Slide.
there's delay.
Next slide. الحاسبة مالتك تعبانة.
لا
Next
دكتور I the most update computer
العاد ليش ما يطلع؟
ما
المهم.
يشغل القديم عمي.
Now I would like to talk directly to Dr. Shahzad here, because if we look to now to go backward, I used the hematopoietic stem cells. Some people, they say it's not appropriate to use hematopoietic as this, it is not a mesenchymal stem cell. But if we go further, we see that very small embryonic-like stem cells really are present with the population of hematopoietic stem cells. So my own experience showed that when we use peripherally mobilized stem cells from hematopoietic origin, using the granulocyte colony stimulating factor, it increases the concentration of the cells in the peripheral blood. We just collect it by the machine and then inject it. We got better results than using the bone marrow-derived stem cells or the adipose-derived stem cells. I am talking about minimal manipulation. I'm not talking about expansion, because till now, we don't have a proper GMP lab. We have a research lab only in 2 areas. So we got results with autoimmune disease, especially. I got a result with hematopoietic stem cells, which can be used, I mean, minimal manipulation. You take it and you inject it. You don't have to expand. Next slide.
May I give my comment on it?
Yes. Yes, please, Dr. Shahzad.
Yes, Dr. Majid, you are talking about peripheral blood-derived cells of hematopoietic lineage.
Yes.
The cells we are harvesting is non-hematopoietic. They are not the hematopoietic lineage. That is the difference between VSCL and the hematopoietic derived stem cells from peripheral blood. So
True.
kits used maybe at that time, those kits were not developed by the Hemnetics when you performed this peripheral blood procedure. Now
True.
they have specific kits developed for it, and with that, I mean, we already have documented surface markers, the characterization by Baker's method, everything, that they are non-hematopoietic, but they are pluripotent. While all the cells which we get from peripheral, this bone marrow, BMAC, or the adipose derived, they are multipotent.
Yes.
So theoretically, these mononuclear cells, which are non-hematopoietic lineage, have greater potential of healing, regeneration, and differentiation into more kinds of cells as compared to multipotent.
So I think we will meet in the near future, and we can cooperate
Inshallah, next
because
year we all will meet, inshallah. Next
in March next month.
February,
Next,
February.
yeah, February, yes.
Yes.
So this is the SVF. You all know the content. You go to the next slide. Next slide, Dr. Khalil.
This is delay. There's a delay.
There's a delay. Okay. So we
Okay.
have the three methods of separation of SVF, including the enzymatic, the ultrasound, and the mechanical. Really, we found with Dr. Khalil that the ultrasonic method is more effective, simple, easy. Not our team only. Even in India, they use the same method, and they got very good results, and they are easy to handle. And you all know the adipose-derived stem cells. Next slide, please, Dr. Khalil.
Yes.
You can run over 4 slides rapidly. These are the enzymatic method for separation of SVF using collagenase enzyme. You can run through it. 4 slides.
Yes.
Next. It takes time. Yeah, this details of using collagenase to extract the SVF, and the FDA marks the use of collagenase as more than minimal manipulation. They consider it as drug. So there is some debate about it. Now, this is mechanical. And after that, our method for ultrasonic stromal vascular extraction, which is easier, cheaper, and it's better, and we can extract cells easily. This is our method. This is in our lab. Next slide shows the pellet.
And we will have a product in the market about the new device. Yes.
Yeah. So the next slide showing if you see the tubes, the 2 tubes, at the bottom you have the white area, which is the cellular part, which is what you call stromal vascular fraction. Next slide. Now, mesenchymal stem cell, they can be taken from SVF, bone marrow, dental, endometrial. Those pictures from our lab. Next. We talk about Wharton gel extraction from umbilical cord. And this is, what is Wharton gel? Wharton gel is a gel that usually contained inside the umbilical cord, circling the 2 arteries and vein. They usually change by temperature. They constrict the vessels usually. What we do here, this is the cord has been transected. Next slide, you put it in a media, and then you cut it and you put it in the media. And the next slide, you can see the Wharton gel mesenchymal stem cells. So this is tube containing the media for the media, and this is the MSCs, the mesenchymal stem cells culture from Wharton gel. Next slide, talking about mesenchymal stem cells. The old theory that it can be delivers tissue regeneration, can be differentiated to any type. And in Kaplan 2011, it's changed. Now, the theory is that MSC is medicinal signaling cells rather than true stem cell. This is very important. And also, it is immune modulator. Next slide showing the mesenchymal stem cell surface antigen marker, which are 70, 90, and 105, while CD34, which is hematopoietic, is negative marker. So you have 3 markers which are positive: CD70, CD90, and CD105, while CD34 is negative. Next slide is talking about natural killer expansion and dendritic cell expansion. Now, natural killer expansion is drawing much attention nowadays, not only in the tumor, solid and hematological tumor, but also even in other benign conditions like autoimmune diseases, for example, and liver disease. So it has a wide applications, and we are running a natural killer cell expansion for experimental purposes in Iraq nowadays with Dr. Khalil and our biologists. Next slide. We have the committed cells, like they are like the neuroprogenitors, the cardiac, the endocrine, the renal, the hepatocyte cell. Next slide showing our motor neuron differentiation in our lab. We did SVF extraction by our ultrasonic method, and then we did differentiation. We used a certain cocktail to differentiate those SVF into neuronal cell, and this slide shows the CD marker, which is typical of motor neuronal differentiation by our lab biologist, who is Dr. Ahmed Shammari. The next slide also is our cells, very clear. Next slide is talking about the efficiency of the product. If you give a product, what you need? You need the count to be a good amount or good number of cells. They should be viable. They have the potency, multipotent. So next slide, Dr. Khalil. And then the site of injection. So we need the count, viability, potency, and site. Then we'll talk about what techniques are available inside Iraq. Definitely for Dr. Shahzad, he has a much better capabilities, and we will meet and talk in depth. What we have is the peripheral stem cell harvest, the bone marrow, the adipose kit 1, اللي هو الانزيماتيك, adipose ultrasound, and culture cells. Next slide, please. Now I will run rapidly through our major articles through the last 15 years, published in different journals, international journals. One of them is talking about multiple sclerosis. And as we talked about, we used peripheral blood mobilized cells. Sometimes we use the bone marrow, and some of the people we use the SVF. And we got good result, improvement in the EDSS score. Next slide is about spinal cord. One of the good articles which we published is we published around 277 cases of spinal cord injury, and we exceeded 300. We saw the difference. Sometimes it was transient, but in others was permanent, and we were pleased to have some problems were solved, including impotence, and some patients showed improvement in sphincter control and also sensory level. So we got a very good experience in spinal cord injury, though it was a primitive, simple, and people are running a better technique. That was an older one. Now for the epilepsy, also we have, that's the next slide, Dr. Khalil, epilepsy. We treated around 23 cases of epilepsy, which were aged 2 to 39, 8 females and 15 male, with multi-drug resistant epilepsy, at least after 3 months of diagnosis. And 23 patients were kept on drugs, more than 2 drugs, 80% 2 drugs and more. All the patients underwent autologous bone marrow mononuclear cell infusion intravenous only. Out of 23 patients, 14 showed improvement, so 60%, in seizure activity in form of 50 to 100% reduction in the seizure activity in 6 months after stem cell therapy. In addition, there was improvement in appetite and sleep rhythm. In diabetes, also, we have a lot of patients, and we got improvement. We use also bone marrow aspirate, given intravenously, and some through the catheter, intraarterial, and also we use peripheral blood stem cells, and also SVF. All types And the conclusion is that in all cases, we got improvement in the for the type 2 in the insulin resistance reduction. For the people with type 1, improvement in the production of insulin, the C peptide is elevated, the HbA1c reduced. And sometimes we go through a partial diabetes remission, which is next slide. And I don't want to go in details because it takes a long time. We got definition of partial diabetes remission. Then we talk about cerebral palsy. In cerebral palsy, we have more than 242 cases from 2009 till 2019. Female patients were 85 and male were 157. Improvement happens in 110 cases, around 45%. In Citroc, we use two types of injection, either intravenous, intrathecal, and sometimes intraarterial through the carotid bypass, intraarterial injection. And we got improvement in the European scale of Citroc. Now we go to your interest, orthopedic cases. We registered two trials, as I mentioned, that we did a US clinical trial. We have its number here. And also bone marrow cells, the second trial, which is registered in the US clinical trial website, is that the bone marrow cells with cord decompression for avascular necrosis, we registered 10 cases. The first one, we got results, and now the results will be published soon about using bone marrow aspirate concentrate in treating osteoarthritis. The second one is bone marrow cells with cord decompression for AVN treatment. Still, we got the results, but we will publish soon. And also, we have experience in hemophilic arthropathy. We used SVF, stromal vascular fraction, in hemophilic arthropathy. You got very good response. For fertility issues, for male fertility, we get very good improvement in people with spermatogenesis arrest, those with aspermia, azoospermia, and people, they got fertile after using bone marrow derived stem cells, bone marrow concentrate really, it's not, so we got the injection of intratesticular bone marrow derived cells, and you got very good response. For the ladies, we have very good news that we have a premature ovarian insufficiency. We managed to treat more than 5 cases. They got improvement. They got elevation of the AMH and thymoglobulin hormone. They got a reduction of FSH, and we got the follicle, the ovarian follicle, and then the embryo. So we were successful in more than 3 cases out of 5 till today. And it was very good, and we will have a report about that very soon. And I run through one of the very interesting thing is the hereditary palmoplantar keratoderma. This is the same patient after treatment, after a single dose of injection of, sorry for the delay, there's a problem because the slide is not ready. You see, we were improved his hair texture, his skin, it was thickened. We got improved. Yeah, this is the patient. It's a form of palmoplantar keratoderma with woolly skin with single autologous bone marrow mononuclear cell infusion. Next slide is talking about first as you know, we started bone marrow transplantation. I started in Iraq in 2003. We did the first allogenic in 2003, and then first autologous in 2004 with Italian doctor, and then we started the cell therapy in 2008. Next slide is about our patents. We have 4 patents till now, inventory patents, I mean, in stem cell, and with different issues. I don't like to elaborate more because it takes a lot of time. Now we go to the other slide, the CV. And so these are the inventory patents. And then you can go to the other slide because this is regarding me, I don't know. Next slide. Our team with Dr. Khalil running the the pain management and regenerative medicine can collaborate, can have a lot of achievements. We can get a lot of achievements if we collaborate. Now for Al Zaytun Private, which we are running officially, and we got approval from Minister of Health in Iraq, it's rare to give such sort of agreement. We have consultants from different specialties: urology, orthopedician, gynecology, hematology, biologist. We have pain management. We have oxidative medicine also, like hyperbaric and ozone, and people from molecular biologists. So we have a lot of people. Next slide are the so we came to the end, and we see here a patient with advanced. Next slide.
Hello, Dr. Abdul Majid.
Running through. Thank you so much for your kind attention and hearing this prolonged. It was technically difficult. Thank you all.
Abdul Majid, really, it was an amazing and outstanding lecture. Thank you for time, in this time and effort, you and Dr. Khalil. I will leave the floor to Yasser Hassan to moderate the session with Dr. Abir and all my dearest friends here. Dr. Yasser, Dr. Shahzad, so for you.
Okay. Okay, thank you, Dr. Khalil, Dr. Abdul Majid, for the amazing presentation. And we have some questions from the floor and from our team itself, but we'll start with the first question. I think from Dr. Peter, I think he asked this question 2 times regarding the dose of calcium gluconate to activate the PRP. The dose of the calcium gluconate for activating,
Yes, calcium gluconate, we activate with the PRP about 0.5 up to 1.
Okay.
Yes.
Yes, sir. Sorry, because I don't write. Can I get two question and to keep silent forever?
Yes.
Because as I said, I want to learn. Yeah. First question, I think it is a very raw materials for research, because even different consensus about the management, like Pakistani method, Egyptian method, Iraqi method, and this is what I found in literature. There is no consensus about everything, and this is a very good raw material for research, and I think we can learn from Dr. Abdul Majid, Dr. Khalil. But I have 2 questions. You speak a lot about many things in the horizon. But what if I wanted to start So I found it simple to start by therapy, PRP, and stem cells. That's it. What do you
Yes.
think?
About prolotherapy,
No, just when I want to start a program like an regenerative
yes,
medicine because it is just a very heavy meal for me. I can't digest all this information. So
yes,
I ask when I want to start. So
yes,
can I start by this very simple thing and to go, or
yes,
what I can do
yes.
from your
So
experience?
at first, I'm start with hypertonic saline, hypertonic glucose. Then I start according to protocol of American regenerative medicine. Start with the type of cells with all types with Dr. Abdul Majid. So I know you cannot first digest this subject, but it will be very familiar to you. Yes,
Yes, sir.
Can I
Um,
can I can I can I
yes,
just comment because really, Doctor, we need a long time. I mean, discussion with Doctor Shahzad and with you. We don't need to talk a lot, but we have a lot of things to do. But you know, what is the FDA approved and what is safe, what is approved. So you cannot use everything. We are now working in the minimal manipulation. That is, you take the cell, you do minor changes and reintroduce to the same body. That's okay. So I think it's good to start with these things, though it has some of them, they have level 1 evidence, as Dr. Khalil mentioned in the slides. For the expanded cells, maybe, yeah, it's better, but it's not easy to do and it's not approved, it's not allowed everywhere. Dr. Shahzad will comment.
yes,
Yes, the question of Dr. Yasser, what I understand is not regarding what to use, what not to use. His question is simple, that as a beginner, what modalities we should start and build our confidence gradually. Your as a physician and also the patient's confidence and the improvement in the. So my suggestion would be both PRP and prolotherapy. Right? If we talk of prolotherapy, it could be as simple as using hypertonic dextrose 10%, 12%, and maximum up to 25%. If we are using extraarticular, it should be around 10% or 12%. It should never be 25%. But if we are using intra-articular, we can definitely use 25%, and I've seen some case studies mentioning 50% even, especially if we listen from Andrea Trescott, one of the senior most people doing regenerative medicine. So that is a good way to start. But the issue comes when there are flare-ups, because any regenerative modality means creating a controlled cycle of inflammation in the body to regenerate the damaged or diseased or non-healing tissues, cells, or organs. So for that, we need to generate a controlled cascade of inflammation. So to avoid that, we, for last 5 to 8 years, what we have learned is if we add tramadol, right, that is preservative free, to any re-injection, to any regenerative cocktail. It could be PRP, it could be dextrose, it could be a combination of dextrose, phenol, and glycerin. We can have a separate talk on that, how to prepare that and what about that. But your confidence as a physician and the patient's confidence will always be there if they don't get those big flare-ups. If they go through big flare-ups for a couple of weeks or even longer, they will never come back to you and will always say that this talk of regenerative stuff is useless, right? So for that, give them appropriate painkillers. It could be tramadol paroral along with paracetamol, or phenidine straight along with paracetamol, and then mixing of preservative-free tramadol with an prolotherapy or leukocyte-rich or leukocyte-poor PRP will avoid all the flare-ups, inshallah. So, and also tell the patient that it's not like giving a steroid or giving an anti-inflammatory injection intramuscular. So it will take some time, but once the improvement is there, it will be there for months to years to come. So it will be a sustained and prolonged one. So it's definitely regenerative medicine has great potential, but initially to start with the simpler techniques, select those patients who are not grade 4 plus, or who have no comorbidities. So be safe, have some good patients with not very prolonged history, no comorbidities. So that will give you confidence and will give you confidence to patient and their families. So that's my opinion or advice.
And
Thank you, Dr. Thank you, Dr. Shehzad, for that. But in Iraq here, we cannot get grade 1, grade 2, as Dr. Abdul Majid know. Grade 1, grade 2, they go to orthopedics. They gave him analgesia. So here in Iraq, I get the grade 3, grade 4 with deformity. So I start with these categories.
It's same with us. As a
Yes.
pain physician,
Yes,
I mean, first people go to the family physician,
yes.
then he will refer them to orthopedic surgeon or rheumatologist or neurologist. Once they take their hands off and they can't treat, then they refer those patients to us who are stubborn cases, who are not being treated. So that is where we pain physicians and regenerative specialists, their role comes into. But again, saying this, instead of taking a 90-year-old male or female with grade 4 and all the varus deformities, I mean, we should take relatively simpler cases which will respond better to simpler regenerative modalities like dextrose, DPG, or PRP. That is my point, sir.
First, I want to thank Dr. Abdul Hamid and Dr. I want to thank Dr. Abdul Majid and Dr. Khalil for their great lecture. They are great as usual, and they open a great opportunity for a group of patients who seem to be hopeless before, but now there is amazing opportunity in front of them. I have 3 questions, which I will be grateful if they help me on it by their experience. As you know, Dr. Abdul Majid and Dr. Khalil, I am working in Ortho and Spine Center. Number 1, the first question, the ortho surgeon have some concern as regard the injection of the whatever, the BRB or the stem cell after the surgery on the same spot of the surgery, because this is what I suggest, that before getting out of the surgery you can put it, but they have a concern as regard that the edema of the surgery, which may dilute the effect of the regenerative medication or the regenerative technique that we are using, whether stem cell or the BRB. So I need your experience in this issue. This is number 1. The other issue, you raise the one of the case, which is dermatological case, which is considered to be congenital. There are some rare cases like hydrantritis suppurativa, which if there is a problem in all sebaceous cysts on the body, what's your recommendation to inject the stem cell or the BRB on the site of the lesion, or to inject intravenous? Thank you.
So what is the third question?
The third question,
highly concentrate, Dr. Shehzad.
I feel that I take a long time, so I try to minimize it. The last question is that, again, the route of administration, in which, how you take your decision, like for a stroke, for example. You said you can inject IV or you can inject intrathecal. What's guide your decision? This is number 1. Number 2, as regard the injection intrathecal, what's the worry about the infection and how we can protect about it? Because if any infection happen in this area, like meningitis or discitis, if we inject intradiscal, it will be a big issue. Thank you so much.
I will start from the, if you allow me, Dr. Khalil, I will start from the last question. We did a lot of cases, intrathecal injections. We didn't get any infection. Only one case, I remember, had simple meningitis, which responded to treatment. And most of them are immune competent. And the amount which we inject is very small. So we didn't come across any complication. It's not an easy job. It's to have such procedure. We met a lot of people and doctors and a lot of problems. But in general, we go through. So it is safe to be given intrathecal. The site of injection, it depends on the pathology. If you are talking about the neurology, we prefer the intrathecal, the intra-arterial, but we should be very brave because it's not an easy job. It's not an easy job.
Yes.
For the skin, it seems logic to inject locally. And Dr. Khalil can complete the other question.
Thank you, Dr. Abir. As you know, Dr. Abdelmajid, me and him about years work, and we all injection we start in theater operative room under highly aseptic conditions.
The conditions.
Yes, easy, so me, as I combined with Dr. Abdelmajid, I didn't get any infection. Just intradiscal injection. Pre-procedure, I gave him IV antibiotic. Just, it's very risky. Get patient discitis.
Yes.
Otherwise, we got no any infection.
And okay, done. Thank you.
But Alhamdulillah, shukr, me and Dr. Abdelmajid, not all cases we published, we work, still working on other cases. We have a lot of cases. I told you last year 1,144 cases. OA, osteoarthritis with the avascular necrosis, all this orthopedic. And we start before months, me and Dr. Abdelmajid work only on biomaterial. We start to upgrade in our work.
About the volume of the intrathecal, how many ml you inject intrathecal?
Intrathecal. Yes.
You don't exceed 5 cc.
Yes.
Okay.
That's
Thank
true. And there is one phenomena, we call it homing.
Yes.
Homing, yes, because all the degenerative or the inflamed tissues in the body, they give SOS signal in the form of generating cytokines, chemokines, all those things. These act as very strong magnets for the stem cells. So with my experience and with other people, we are working in collaboration with US and Europe. We stopped doing all intrathecal procedures before COVID because there is no published evidence of giving intravenous or intrathecal. The maximum in our practice, what we do is fluoro ultrasound guided transforaminal, right? Epidural, not intrathecal. In those cases who have phantom limb pain or other sort of neuropathic component, in addition to IV infusion, and also because all the joints, they have very limited blood flow. So in addition to IV, we give intra-articular, especially for spine, in intradiscal injection, because there is no direct blood flow. It's through the end plate, very minimum blood flow. So for those tissues who are depleted in blood flow, for those we can give local, intra-articular, intradiscal. Otherwise, giving IV is good enough with very fair evidence. What about, what's your comment, Dr. Professor Majid, on it?
Yeah, Dr. Shahzad, I think we need to have a proper discussion, maybe in a stimulating environment. This group will go, for example, for some area in Pakistan or India to talk in depth about what should be the next step, really. We need to, as Dr. Abir suggested today, that we can have a parallel group like the Americans and the European. We can have our local Middle East, African group, Asian. We can have our own idea, our own theory. I mean, we need, it's not convenient to talk now. We need a lot of discussions with you and with our members of this group. I mean, a lot using the cell, the type of the cell, how to inject, expanded, non-expanded, allogenic, autologous. A lot of questions need to be answered.
Dr. Shahzad, sorry, so long we are here. Epidural, what's the volume that you recommend?
Again, it depends on the level where we are giving. If I'm giving it for refractory CRPS patient with muscle wasting and everything, I will not exceed 1 ml in cervical region. For dorsal, for shingles or any sort of other refractory pain, we can go up to 3 ml. For lumbar at L5, we can go up to 5 ml, right? Transforaminal.
Yes.
So that is the rule. So for cervical, 1 to 1.5, 2 to 3 for dorsal, and 4 to 5 for lumbar levels.
Thank you, Doctor.
Dr. Shahzad, last week we came across a patient with limb girdle muscular dystrophy, and we did a procedure of bone marrow-derived cells, and there was a fantastic improvement, really. She never got such improvement for the last 10 years. Really very encouraging results.
So what route of administration did you opt for? Intravenous?
Just intravenous.
Yes, that's brilliant. That's brilliant.
Even confirmed by the EMG, the people with the electrophysiology, they confirmed that she has improvement, which is very good result for her. Thank you, Doctor.
Yes, thank you. That's brilliant. Yeah, that's a new window of hope for everybody, this regenerative, yes.
Yes, yes.
Thank you for our great panelists, but allow me to add something regarding Dr. Abir's question.
Please, can I have a comment here, sir, please?
Okay.
لازم تسمح لها، دي الرئيسة لازم تسمح لها.
So now we have a hot game. We have those both two great professors, Dr. Abdul Majid and Dr. Khalil, about the intrathecal administration of stem cell or PRP, and Dr. Shahzad. So this is a very good game between Sadio Mane and Mohamed Salah. And we will transfer this game to
Pakistan
in our hospitals, and we can do two team works, and you can advise us how to proceed for those and to be a multi-center study, and especially after you come in Egypt in May to have your workshop. We will have two teams, one acting on Dr. Shahzad idea and the other for Dr. Khalil and Dr. Abdul Majid idea. And we, of course, the result will be very valuable and beneficial for our patient. Thank you.
And there will be a third group where we'll be combining both the...
Yeah, this is better. Combination is better.
Yeah.
The good issue is that Dr. Safa confirming that inshallah in the conference in May we will do practical cases and practical workshop on a real patient who will get a lot of benefit from this great panel, Dr. Shahzad, Dr. Abdul Majid, and Dr. Khalil, inshallah.
Of course, it
And
is
you as
my,
well, Dr. Abir.
of course, it's my golden chance to catch them
Yes.
and do
Yes.
my best to have this golden chance.
Inshallah.
So before May, we have our conference in February. So we will be there for 3, 4, 5 days, and inshallah we'll form a working group to start with, and then we can form a properly registered group, or say Afro-Asian
Exactly.
Society, Afro-Asian Society for Pain and Regenerative Medicine,
Yes.
something like that. Because I mean, our lifestyles, our genetic composition is much more closer. I always quote one example that starting dose of pregabalin in Europeans and Caucasians is far higher as compared to Asian and Muslim population. If I start with 150 mg of pregabalin, my patients will never wake up. So we need to start it with 50 mg or even 25 mg. So
We can start, Dr. Shahzad, with the working group, which is easier to develop.
Yes.
Working group,
Yeah.
because associations or academy needs more approval.
I mean, we'll keep on working parallel. We'll start working with the working group immediately. And then in the meanwhile, for a long-term sustainability and expansion, we need to form formal Afro-Asian, a bigger, a properly structured organization.
Yes, Dr. Shahzad, I see that we have a great leader in this field, and we can do a lot in this field by this great leader. And we have a good number of patients that we can make it working on them, and we can get a good result. But the issue that we are not documenting, but Dr. Abdul Majid and Dr. Khalil document most of what they work. So we can do something better to the American Academy of Regenerative Medicine at the level of Africa and Asia. We have all the leaders here from these countries, so we can do the Afro-Asian or something like this, which is go parallel to the American Academy, and we will be leader in this to put our guidelines, our protocols, and our consensus.
That's true, but it will take some time.
Exactly.
Yeah.
Yes, as Professor Abdul Majid said, that we need to start by forming a working group, right? And then we can choose some, say, treatment modalities or some products to start with, and then gradually we can build on it.
Exactly, yes.
So, Yasir Tayyib, please introduce the other question. I think Dr. Muhammad Afandi has many questions. Dr. Yasir Tayyib.
Yes.
Dr. Muhammad Afandi, if you are present here, please unmute yourself and open your video. Dr. Muhammad.
السلام عليكم ورحمة الله وبركاته. ازيكم جميعا؟ How are you? Very, very, very interesting lecture and series by Dr. Abdelmajid, Dr. Shahzad in 2 consequent weeks. Very interesting. I have 2 questions, namely, what about PRP in carpal tunnel syndrome? The results, I have a research work doing now. I found some controversial data. I found that BRB was limited duration of a success in carpal tunnel syndrome. Also, Dr. Abdelmajid, what is the ideal protocol for AVN of head of femur? What we protocolized form? Shall we do decompression first? Then, after what period we will give a PRP or any other modality of regenerative injection to be performed? I need these 2 questions, really. We meet too many cases of this, and we feel really hopeless for such cases, just waiting for replacement of the hip joint and delay of decision as they are young, needing time for avoidance of redo operation after 7 to 10 years. What shall we do? Thank
Dr.
you.
Shahzad will answer first, and I will.
So regarding the first question, the studies showing limited role of PRP in CTS. Now, there are two problems with these studies. If you go critically through the methodology, you will find they have never mentioned the concentration of the platelets, whether it is more than 1 million or less than 500,000. So most of the negative studies, not only for CTS, but also for other negative studies, the problem with them is methodology. None of the editors or the reviewers, they don't ask for, so people love to publish negative studies regarding regenerative medicine. This is one aspect. The other aspect is many of the CTS patients are misdiagnosed. Sometimes the CTS like symptoms, they come from cervical compression, radicular, or all those sort of patients. So if the pain is coming from cervical compression, whatever we do steroid, we do decompression surgery, whatever, it will not improve. So these two problems, one is the wrong methodology of PRP, and second, the misdiagnosis of CTS. That if they are ruled out, I can assure you I have more than 500 published cases of CTS properly diagnosed with EMG and all those things. One shot of PRP gives more than 2 years of relief. Right? So it should be in proper concentration, and that is leukocyte-rich PRP. And no study you will find will state whether it is leukocyte rich, leukocyte poor, or so all those negative studies, I mean, I would not trust them.
The other question?
Yes, most of the studies really, none of these negative studies made a histopathological examination of the concentrate. Really, you told us in the previous session that the least effective dose is 1.5 to 3 million per microliter will be efficient. None of the studies gave us a result, mentioned the number of platelet per concentrate. I assure that. Yes, Dr. Shahzad, I am with you in this.
Thank you. Thank you. Thank you so much.
Thank you, Professor. Thank you very much. And thank you all for such illustrative presentation. And I am waiting for May. From now, I am counting days till participation with you.
Yes, of course you are welcome every time,
I mean, you
Muhammad.
don't need to wait till
Always spend your time
till
and
May.
effort.
You can
Join
come
us.
to Lahore in February and join us and learn lots of things about regenerative.
Yeah.
But before you go, Dr. Effendi, you have the second question not yet answered for the hip, for the air vascular necrosis.
Yes, yes, Dr. Yasser.
Dr. Khalil will respond.
For avascular necrosis, we start. He asked about
Core decompression.
decompression. Okay, and I will share you a slide for. This is a slide. Maybe you see it.
Mm-hmm. Yes.
Yes, yes, yes.
This is avascular
Yes,
necrosis.
I see.
This is before and after. Me and Dr. Abdul Majid here, we use bone marrow aspirate, first decompression, then we invent a new approach for injection for this femoral head, but I have a few slides as I recommended, and I am inject inside the head of the femur. You see this femoral head crest fracture with cyst and start to become flat. After I inject a new approach, me and Dr. Abdul Majid, without help from orthopedic, we invent a new approach. We call it KM1 and KM2 into the head. You see, this is after nearby 1 year. This changes. He came to us for emergency hip replacement.
In the same session of decompression or after
Yes,
decompression?
next same session.
Yes, clear. Yes. Yes, moving. Yes.
It's clear, the picture.
Yes, it is a clear. It's clear. Yes.
Okay. I have many picture, but there's a problem in laptop of Dr. Abdul Majid. So I don't prepare it on this laptop.
Thank you, Dr. Khalil. And I
Thank
think
you.
nowadays, yeah, there is an ongoing.
Just
I
one
have a
minute.
question.
Yeah.
Yes, in addition to decompression and intra-articular injection, and also the recent studies have proven that subchondral injections
Yes,
around the acetabulum, and as you did in the neck of femur and also the head of femur.
yes.
But the issue of going into the head is the only artery which already has been damaged. So one has to be very, very careful when we go beyond the neck of femur. So
Yes.
that is very important to preserve the very little remaining blood supply, which already has been compromised and everything. So going into the acetabulum for subchondral and also into the neck of the femur is much more safer, and that gives outclass and very accelerated results in avascular necrosis of head of femur.
Yes, Dr. Shahzad, thank you for this comment. But me and Dr. Abdul Majid, we invent a new technique we made a new needle. We don't use the orthopedic needles. Now me and Dr. Abdul Majid, with engineer from China, okay, he will produce this product, a new product, for intra subchondral with injection into the head of the femur safely, and the patient will discharge after less than 1 hour. Orthopedic, orthopedic, they use drilling from the greater trochanter, and the risk about 50% fracture neck. Me and Dr. Abdul Majid, this new technique, more safe, and the patient discharge home after less than 1 hour.
That's true. That's what we are doing as well. We are not using any Tomshedi or Jamshedi needles. It's just the maximum 18 gauge needle, and with an introducer, and then we introduce when we are in the cortical, then we use blunt needles to avoid blood vessels. So that is,
and
there are different techniques.
To get approval, yes, to get approved, I am injected into the head. I mix the stem cell with contrast, take a few pictures with fluoroscope. This should be documented.
Yes, and in addition to it, ultrasound guidance will further help with Doppler flow.
Yes, better, yes.
Okay, thank you. Thank you, all the panelists.
Assalamu alaikum. Assalamu alaikum, Dr.
Have we time?
I have a question.
دكتور وسام.
Hello,
Question?
Dr. Abir, Dr. Safa.
ازيك يا دكتور وسام عامل ايه؟
Dr. Abir.
ازيك؟
First of all, thank you for Dr. Abdul Majid, Dr. Khalil, and of course Dr. Shahzad for their contribution. Really, all of us are proud to have such scientists in our world. So thank you. My question is about when are using the even stem cell or PRP for such medical cases. I want to ask, is it single injection, only one session of injection, or we might repeat it to get the best results? This is number one. Number two, what is the successful rate? I mean, all of cases got improved after injection, or with different levels according to the stage of the disease. Number three, regarding the case of multiple sclerosis, does the improvement was in the clinical level? I mean, low incidence of attacks, or even in the image level that the focuses or the foci or the lesions are vanished from the MRI. So this is my questions. If you please to answer it.
I start from the third question regarding the multiple sclerosis. We used only, we just treated the people who are progressive, not the relapsing remitting, because they say that if we give the treatment, they say it is natural history of the disease. So we treated them. We got the EDSS score, the clinical score plus radiological. We got improvement in the MRI after 6 months of treatment. And the lesions, for the lesions in the MRI.
Yeah.
It is
only one session of treatment, or multiple sessions?
No, multiple sessions. One session is not enough.
Not enough.
So,
Yeah.
So Dr. Abdelmajid is only for the progressive cases only, not for the relapse and the progressive MS or the other issue.
Because it's ethical, because people, they got relapse and remission.
Yeah.
The doctors will discuss, will argue, because the patient will have remission by himself. So what is the role of your treatment? But if they are progressive and you stop the progression and you improve, this is the true evidence, the solid evidence.
Yes. Of course, as you know, Dr. Abdelmajid, that multiple sclerosis is the second cause of disability worldwide after trauma. So yeah, it is, and I'm so sympathy because it is common in female. So I want you to more research about this issue, please, Dr. Abdelmajid, Dr. Khalil. Because
I think with Dr. Shahzad, we can do a better work with Dr. Shahzad.
Just because common in female, Dr. Safa, just because common in female.
Yeah.
It will not only be 3 of us, there will be many of us, inshallah.
Maybe the male has the progressive form and the female has the remission and exacerbation because of pregnancy, as this disease is mainly dependent on immune aggression. So in pregnancy, she has a quiet phase and early in the postpartum period.
Me and Dr. Abdelmajid always say, teamwork better and faster, and we work as a team.
Yeah.
Inshallah, in future, we will be with you, our team.
Yes.
Inshallah.
Just I think, yes, Type, please. Just I think that I want to ask a question about if the patient age, the patient comorbidity, the multi-drug, the patient receiving multiple drugs have the same response like the other entity of patient in PRP or stem cell therapy, or all this cofactor may influence the success rate of stem cell.
Yeah, morbidity influence, yes, because if you have a patient who is immune compromised, multiple diseases, I mean, the response will be less. The stem cells are, the type of stem cells, it depends on the bone marrow and, for example, the peripheral blood, the adipose tissue. Sometimes you got SVF with the cells that is not working, for example, because most of the adipose tissue is dormant. They are not active. You should be activated by phototherapy or by PRP, etc. So everyone has a potentiality of his cells.
With age group.
Yes. So we may have some prediction of the prognostic value of stem cell. How to predict that this patient will be successful when have stem cell therapy or PRP?
No one can answer.
Yes. But for every disease, if the patient presents early in a younger age, we'll have better outcomes as
Yes.
compared to an aged person with multi or 20, 30 years of history, right? And then another question of how many sessions and how do we decide that this patient will need this number of patients, right? So it again depends upon the age. If patient is younger with a shorter history, maybe one session is good enough. And if an aged person with a prolonged history, there is the probability of giving multiple treatments. That is so one protocol which we have developed over the years is, because the science proves that with every passing year or every passing decade of life, the number of stem cells they fall, especially after the age of 40 years. So at our center for last more than 10 years now, we never ever go straight so we never start with the stem cell treatment. What we do is we give 2 to 3 sessions of PRP with or without detox. That means we add ozone in the autologous blood and multivitamins, all those things, and we give this intra-articular, intradiscal, or simply IV. And we have proven in our papers that the number of cells, both hematopoietic and especially MSCs, they increase in response to PRP and detox treatments. So as this is much less costly and less invasive as compared to multiple stem cell treatment, so this can be a good protocol to give 2 or 3 sessions of PRP with or without detox, and then go for the stem cell treatment. Then we'll get a much better harvest, and both in number and quality of the stem cells.
I want to thank Dr. Safa for her concern, and I want to also to acknowledge it, that discussion with the patient is very important. In our center, we are always telling the patient that this is a new kind of a treatment. There is no enough evidence or data about it. And even we arrange with the quality department to prepare something like agreement with the patient, that everything is discussed. The result may be good, maybe not so good, because it's still under research and there is no enough evidence. So this part is very important. Discussion with the patient is very important. Giving all the perspective is very important, because sometimes the requirement of the patient or his ceiling is very high. This must be manipulated in a very good way to give a good result, because the good result will be variable from the doctor perspective, different from the patient perspective. That's all.
Dr. Abir, from the first, me and Dr. Abdul Majid, the first we start how to key of selection of patient, and we categorize the patient geriatric and young. The geriatric also sub-classified those with comorbidity and with none. Also, according to dietary habit, smoker, alcoholic, those different from other. So before we start, me and Dr. Abdul Majid, we assign a concept with the patient. You know, those patients, it's a new medicine. It's a new medicine. Not all known about. So when patient come, we make assignment plus. Most of the patient come, he is desperate. He make tour around all doctors. Then we get this patient. So I think I see me and Dr. Abdul Majid. This is also benefit, because he has no other solution, only us. So when we start, we start with our protocol. We put protocol here in our work at Zaytoun Hospital. And this is, I'm grateful to Dr. Abdul Majid. he has long يعني يعني باله طويل علي. I think Dr. Shahzad, you don't understand.
So patient, he's patient with you. Dr. Shahzad, we want to
He's
see
so
that.
patient,
Dr. Abdelmajid is so
so
patient.
patient.
Yeah,
So we carefully select the patient.
Yes.
Plus carefully and highly selective, we have a lot of patients.
system. So what is called the precision medicine and the personalized and tailoring the treatment according to the patient phenotype and genotype. So Dr. Khalil, we have a question from our respected colleague Iyad Fadil. Are you here,
Yes.
Iyad? Are you here?
Yes.
Iyad. Iyad, are you here?
Dr. Ayad.
So he asked about why those expensive biologics not better than dextrose prolotherapy, especially some the dextrose prolotherapy studies are treating bio.
Tensegrity.
Good evening and highly appreciated. Yeah.
Are
Do you
you
hear
here?
me? Do you hear me? Yes,
Yeah.
I'm here. Do you hear me right now?
Hi, Dr. Iyad, how are you?
Hi, I'm fine,
Yeah,
Dr.
yeah.
Abir.
Yeah,
Do
you
you
can
hear me
ask
right
your
now?
question. So ask your
Do you hear
question
me?
directly. Yes,
Do you
yes.
hear me right now?
I
Yes,
can see
First
his
of all,
question.
Ask your
first
question.
of all, I highly appreciated your lecture, Dr. Khalil. You are unique in everything.
Thank you.
You and Dr.
Thank
Abdel
you. Thank you,
Majid.
Dr. Ayad.
I'm following all your performance and all your results in biologic.
Thank you,
Right
Dr.
now,
Ayad. Dr. Ayad.
I just want to
Yes,
ask
I
you
see your
about Stanley Lam. Stanley Lam. Yeah, Stanley Lam. Stanley Lam.
Yes.
This is a question of Stanley Lam. He asked many questions about biologic and prolotherapy, dextrose, using dextrose. A lot of study, randomized control trial, and many studies talking about dextrose, treating the biotensecurity and treating the body at all. Like knee, you treat the knee intraarticular and treating the tissue around the knee. How do you respond to this dextrose when you compare dextrose with BRB and stem cells? The same results. How do you respond for this question?
No. Dr. Ayad,
Yes.
as Dr. Shahzad here, prolotherapy, from healing cascade, you inject hypertonic, you made injury to cartilage to make inflammatory, then proliferative, then cascade, remodeling. Is that right, Dr. Shahzad?
Yes.
And in our biology, biomaterial, we use the biomaterial like cellular and acellular. This is faster than prolotherapy. It is so expensive, yes. Even the material, Dr. Shahzad, But prolotherapy we can use for other cases. Yes, in the past, in our all books say dextrose prolotherapy, but it's not better than biomaterial.
You mentioned, Dr. Khalil, you showed most of the review articles. You
Yes.
have a solid level 1 evidence.
Level 1 evidence.
So,
Yes.
the question of Dr. Yad was regarding biotensegrity. Biotensegrity is related to the ligaments and tendons that support the spine. So there is lots of talks given by Aggie on different platforms, and we have shared lots of discussions together on this topic. As far as myofascial pain is concerned, I would agree 100% with Iyad that there is no difference between injecting high cost cellular or biologics or giving properly prepared and properly injected prolotherapy. But this is only for myofascial pain. If we talk of systemic conditions, or if we talk of degenerative conditions, right? In spine, the basic problem is with ligament laxity, which leads to secondary muscle spasm, bottleneck injuries, increased degeneration, compromised blood flow. So all those things. I will not go into detail. We all are familiar with the degenerative cascade. So that is where if we inject multiple along the origin and insertion of the ligaments in the paravertebral muscles, whether dextrose, hypertonic, or partially hypertonic, or the DPG combo, anything. So that is very, very effective. But if a patient we are treating with, say, degenerative disc disease, you can't, I go through literature every other day. There is not even one published evidence of prolotherapy for degenerative disc disease. There is evidence for PRP level 2. There is level 1 evidence for mesenchymal stem cells from adipose-derived or BMAC-derived. So it's not for all the diseases, only for the myofascial diseases. So that is the answer to your question.
Thank you, Dr. Shahzad. Exactly. Yeah, thank you so much. Yeah, thank you.
I've been silent for a long time. Can allow me to add something, Dr. Shahzad. Regarding what Dr. Stanley Lamb speaks about, he speaks about mainly the carpal tunnel syndrome and the hydrodissection for the nerves. Yes. He had a very solid ground of evidence that this dextrose works much, much better in these two things that you mentioned, plus the hydrodissection and the carpal tunnel. But regarding what you mentioned, this totally can't agree more. Regenerative is much better for the degenerative joints and the other systemic diseases.
Dr. Stanley Lamb, now
also just one example of osteoarthritis, knee or shoulder or hip. That is because of increased number of those proteases, and with age, the function of synoviocytes decrease due to the influence of proteases, right? And if we inject dextrose, that will not affect like I mentioned in my lecture, that alpha-2 macroglobulin from PRP or leukocyte poor area, half a centimeter above the Buffy coat. So that is one of the most potent protease inhibitors. So we need to look into it in more detail. Just by causing the inflammation can cause a temporary relief, but also a severe flare-up in the patients. So keeping all those things in mind, so it's not justified to say that, and also Dr. Yasser, that hydrodissection comes with both. If I'm treating CTS and injecting PRP, leukocyte rich, or dextrose, so in giving injection under ultrasound will hydrodissect. So that is common to both, right? So, but for degenerative condition and especially OA and all those conditions which are immune modulatory, which are autoimmune conditions, and also this prolotherapy, whether simple dextrose or DPG or other forms of like hypertonic saline, they don't have immunomodulation effect. They just have, I would say, a regenerative effect due to inflammation. So keep all those things into mind.
Yes, thank you, Dr. Anwar. Thank you very much. And speaking about the immunomodulation, would you please, all the panelists, you, Dr. Khalil and Dr. Abdul Majid, speak a little bit about the role of regenerative medicine in the rheumatoid arthritis patients and your own experiences in that?
Yeah, I will comment on that point in particular, because we have patients with rheumatoid arthritis. We did many cases 10 years ago with hematopoietic stem cells. We injected intravenous, and we have some sort of bone marrow-derived suppressor cells, bone marrow-derived suppressor cells that suppress the T cell, the helper T cell. So I think we have a good experience, but we need to collaborate more with Dr. Shahzad. In the next meeting, we'll have a better protocol, I think, because we didn't maintain those cases. They need a lot of sessions. The ESR reduced and everything was reduced. And one example is the tissue-specific immune disease like MS. We got good results. We have more than 130 patients. So it's the same idea. We need to collaborate to have a better protocol for the future.
Sure. Okay. So any more questions from the floor, or shall I ask again?
Sir, I have the second question. Can I ask? I'm
Yes,
sorry,
please.
because I see one question here. The second question about people in pain management. Where is the place of regenerative medicine from the protocol for pain management or for the pyramids or the stairs from pain management? Where does this come in the line for the pain management?
Still a primitive. I think they are concentrating only on. That's why we need to enlarge. I need to expand because still they are talking only about PRP. We need to go more with the protocols.
I mean, the question is at what level should we involve the regenerative modality? It's just like you were talking about the WHO ladder or the pyramid, right? So, I mean, for me, if a patient comes with more degeneration and less inflammatory condition, then the treatment of choice should be regenerative. And if patient is young, has more pain because of the inflammation, then first treat pain and inflammation, then go for regenerative. So it's not that we can treat everything with regenerative. We know we should select the patient carefully. If there is more inflammation and pain, then first treat the pain and inflammation, then we will go for the regenerative cascade. But if the aged population or even younger patient, there is an element of degenerative cascade and not any acute or acute on chronic, then we can straight away go for which is very, for as a pain physician, these patients will be very, very low in number. So first the treat should be pain management, because that is the symptom patient comes to me or any pain physician in the world. So once that is treated, after that, we can go for long-term management to avoid recurrence. And like, say, I give the example of festogenic back pain in younger patients and in middle-aged patients, right? Few years back, the only treatment option we had was radiofrequency rhizotomy of the sensory branches coming from dorsal MI. Right? That was the gold standard. So, but now in patients who are younger than 60, and who have a good quality of life expectancy, we don't do rhizotomies. We do sensory branch neuromodulation bilaterally, followed by PRP injections. And patients, I mean, because giving or just burning the medial branch also can cause degeneration of the multifetus, because one half of the medial branch is going to the facet joint, the lateral half is going to the multifetus. So that will cause the problem. So in younger patients, on the pyramid, we can go for neuromodulation along with regenerative. It can be dextrose, it can be hypertonic DPG, it can be leukocyte rich PRP, or it could be stem cell. But this option of performing neuromodulation along with any of the regenerative modality for festogenic pain, and I discussed all the things of multifetus dysfunction and all the evidence on MRI and all that. So that is much more helpful, and it should come down. So it's not any rule of thumb. And if we see a younger patient with chronic back pain, and we don't want to avoid multifidus dysfunction, we can go for neuromodulation along with regenerative medicine. And if there is a patient with acute radicular pain, then definitely first the intervention. Then after that, if there is associated degenerative disc disease, we can go for regenerative modalities.
Thank you.
Thank you, Dr. Anwar. And just a small comment for our junior colleagues. Before any intervention, please speak to the patient, as mentioned by Dr. Abir, that it's a diagnostic block. It may work and it may not work. And speaking about these diagnostic blocks, as mentioned by Dr. Shahzad, how long do you wait after the normal steroid and local anesthetic injection? For example, if you want to do something regarding the knee joint, and one colleague gave some steroid or local anesthetic in the assigned joint that you are going to give regenerative medicine, how long do you usually wait before you do the regenerative management?
It's minimum 2 weeks, but ideally it should be 4 weeks. Right? But as far as pain management is concerned, intra-articular steroid will not help that much if there are involvement of the genicular or the sensory supply. So even if some orthopedician or any other friend of ours has given intra-articular injection and patient still complains of pain, we can go for RF denervation or rhizotomies on the same day, and then followed by minimum of 2 weeks, but ideally 4 weeks for regenerative intra-articular PRP or stem cell or whatever we plan.
Agree.
I think no more questions in the chat box. Shall Dr. Safa, will you take over, Dr. Safa?
Yes, I just have a comment that this is my first time to fall in love with pain and pain management, and this is my first time to hear.
Regenerative medicine.
Thank you. And this is my first time to hear about the regenerative medicine. Really, I like it so more. So I have a proposal for you, Dr. Shahzad and Dr. Khalil and Dr. Abdul Majid, that I will be your first student in Egypt, and I will be the first one to register in the course in May 22, in the course of regenerative medicine. I am be the first student, and it will be my great honor and pleasure. Thank you for your endless support for Egyptian Society of Anesthesiology and Acute Care, ISAC. Thank you for the endless support for our online program and your valuable contribution by your amazing and outstanding information about the regenerative medicine. Thank you for your time. We'll meet again many times. I will leave the January 6th WhatsApp group open to meet for sometimes and in near times after Dr. Shahzad and his duties about his conference in February, inshallah. And we have a surprise. Both Wissam and Yasser will introduce it. But I saw that Wissam may have a comment.
No, it's not a comment. It is about the surprise.
Yes.
We are very enthusiastic to announce about our third annual conference of our Egyptian Society of Anesthesiology and Acute Care, which will be held in Menoufaia Governorate, inshallah, in May 22nd to 25th. And hopefully we will be glad to have all of you to attend our conference. It will be grateful. Right, Dr. Yasser?
Inshallah, we welcome you all, and this is a very nice invitation to all of you to join us and to arrange from now for the regenerative workshop beside the regional and the pain. And inshallah, we're going to work on that with Dr. Safa to make it a successful one, inshallah.
Inshallah.
إن
Of course,
شاء الله.
I let the leader for both two host leader as Yasser and Sam they are becoming leader of the society, inshallah.
Inshallah.
So this is our issue. Share it, please. Share it, please, Ahmed.
You mean Yasser Tayyib, not me.
Yeah. Yes, of course.
All answers are the same.
You are the old leader.
Yasser.
Our chairperson, both Dr. Yasser Zaghloul and Dr. Ahmed Rida, our General Secretary, both Professor Dr. Yasser Tobla and Professor Wissam Sultan, and our Vice President, Dr. Gouda, Dr. Amr Farag, and Prof. Nagwa Doha. All of you are honorarily invited to attend. Of course, please, Dr. Shahzad, don't consider this announcement is a competition with your successful conference, inshallah, but we are going shoulder to shoulder and hand in hand.
Parallel, inshallah.
Inshallah.
It's really an absolute honor and privilege to know all of you, my brothers and sisters.
Thank you.
Thank you, Doctor.
Mashkoor Bhaiya, mashkoor.
It's we are the honored with this, Dr. Shahzad, really. Thank you.
Thank you. Thank you so
ما
very
شاء
much.
الله دكتور ياسر بيتكلم كل اللغات يعني ما شاء الله.
ما شاء
أنا
الله.
ملاحظة أيوة أنا ملاحظة.
Just one humble request to all that will carry on with the 6th of January group, and we can give our suggestions regarding forming of the working group, so that we can officially announce during WPRC 2024, and then we can continue that to the ESAC meeting and further expand that, inshallah.
Yes, inshallah. Of course. Yes, it is just a family WhatsApp group.
Yes, it is.
Yes. Thank you for your time and your valuable contribution.
Thank you so very much.
To give me
you.
the happiness and the pleasure to meet you.
Wish you all good night. See you all.
Thank you.
Thank
you.
السلام عليكم.
دكتور عبد المجيد، شكرا
Thank you,
دكتور
Yasser.
See you soon.
شكرا إياد. Meet you. I'm sorry, just 1 second. Iyad will be our presenter in January 27, and it will be Syrian Isaac collaboration. Thank
Proud
you.
of you. Proud of you.
Inshallah.
Thank you.
My honor. My honor.
Bye.
Yeah. Bye.
See you soon. See you soon.
دكتور فانديل شوفك الله.
Thank you.
السلام عليكم.
عليكم السلام.